Good evening, sir.
We are live.
So, good evening, everyone. Uh, on behalf of VOS, it's my privilege today to welcome you again to yet another session of Wednesday webinar, which, as you all know, is a part of our initiative to have Wednesday webinars with District Ophthalmic Societies in Vidarbha. And today is our fourth webinar in the series, and this is the part two of Mastering the Cataract Surgery. And today we are doing this in association with the Vartha Ophthalmic Society. We are delighted to have with us eminent panelists and respected senior chairpersons. And today we have with us distinguished national guest speakers, uh, Dr. Ragini Parikh Madam and Dr. Chandrasekhar Bhavikar sir. I also take this opportunity to express my sincere gratitude to our dynamic president, whose constant guidance and encouragement has been the driving force behind all our academic endeavors. I request Dr. Viral sir to have an opening remark, please.
Thank you, Dr. Rahul Tiwari, Chairman Scientific Committee, Dr. Neha Deshpande, Vice Chairman Scientific Committee, and the entire Scientific Committee of US for arranging such wonderful webinars on Wednesday of every month and sometimes twice in a month. It is indeed an enriching experience. Sir, Bhavikar sir, as we know, we are celebrating 50 years of Vidarbha Ophthalmic Society this year, and this is the Golden Jubilee year, and we are celebrating it by honoring the past and nurturing the future. So, such webinars are very useful. I take this opportunity to welcome our national faculty, Dr. Chandrasekhar Bhavikar sir. Dr. Ragini Padam is yet to join. Our chairpersons for today, Professor Smita Singh Madam and Dr. Sachin Dayagawane. Dr. Shashank Banayat, sir, and co-chairpersons Dr. Sanjay Oswal and Dr. Sachin Daigawani. Moderators for today, Neha Deshpande and Dheeraj Jaiswal. And our eminent panelists for today, Dr. Ajay Khandewale, sir, Dr. Vijay Jaswani, Dr. Advay Appalwar, Dr. Durgesh Pashine, Dr. Shreyas Damorikar, Dr. Abhay Agashe, and Dr. Ankit Harwani. So I thank the Varda Ophthalmic Society for partnering with us for this webinar, and maximum participation is from Varda district this time. I'm so happy to see we had a wonderful installation last month only, and you are doing excellent work. Lots of activity, tree plantation and eye donation and everything we are doing of this webinar. So congratulations to team Varda under the leadership of Dr. Shashank Banay sir and Dr. Rasune madam. So without wasting much time, I think I should hand over to Chairman Scientific Committee for further proceedings. Dr. Shashank Banay sir would like to add something on behalf of our Dr. Society. Thank you.
Shashank sir, I request you to give your two words before we start the scientific session. Shashank Banay sir. You are muted, sir, actually. You are muted, sir.
Sir, please unmute yourself. Shashank sir, you are muted still. I will unmute him from him. Yes, sir.
You started a whiteboard.
Yeah.
You need to share the screen.
Can you hear me?
Yes,
Yes,
loud.
sir.
Yes, sir.
Please go.
Yeah. At the outset, I would like to thank Dr. Viral Shah, President VOS, and Dr. Rahul Tiwari, the Chairman Scientific Committee with the Ophthalmic Society, for giving us this opportunity to us to have this talk presented by an eminent national faculty, Dr. Parekh and Dr. Chandrasekhar. Without wasting much time, would like to proceed with the presentations, if you don't mind, sir.
Yeah. So over to our dynamic moderators for today's session, Dr. Neha Deshpande and Dr. Dheeraj Jaiswal, sir.
So I think, Dr. Dheeraj, we can start the webinar by, you can start, should we start with the local faculty first? Dr. Rahul sir, you are muted.
Yeah, the session details are there, madam. The first talk,
Yes.
let us
So I
invite
think,
Dr. Archana.
Dr. Dheeraj sir, can you introduce Dr. Archana Thul, madam?
Yeah, Doctor. Yeah. Good evening, all. Dr. Ashna Thul, ma'am, is a professor in the Department of Ophthalmology, Jawaharlal Nehru Medical College, Datta Meghe Institute of Higher Education. So, ma'am,
Dr. Dheeraj, I think your internet is unstable.
Yeah, Archana, madam, you can start sharing your slides. Yeah.
Yes, sir, I've shared it.
Yeah.
Sir, am I audible and my screen visible, sir?
Yes, loud and clear. Yeah.
Can I start with the presentation, sir?
Yes.
Good evening, respected seniors, my colleagues and friends. Myself, Dr. Archana Thun. At the outset, I would like to thank Vidarbha Ophthalmic Society for giving me the opportunity to talk. Today's my presentation is on management of subluxated cataract. By definition, subluxation means partial dislocation of partial displacement of the lens from the patellar fossa, whereas dislocation means the complete displacement. There are various causes for this subluxation, of which commoner being the blunt trauma to the eye, causing 50% of the cases for subluxation and dislocation, followed by when it is associated with systemic anomalies like Marfan syndrome, polycystinuria, or Ehlers-Danlos syndrome. Secondary to certain ocular conditions, most common being the mature and the hypermature cataract, and patients with pseudoexposition syndrome. As far as presentation is concerned, patient usually presents with progressive blurring of vision due to cataract, changes in the lenticular astigmatism, and induced myopia due to positional changes. There can be monocular diplopia due to lens bisecting the visual axis. Sudden loss of vision seen in patients with dislocations. If associated with pain and redness, it is due to secondary angle closure glaucoma or phakic glaucoma. A thorough slit lamp examination is a must, especially in the mild cases where a high index of suspicion is required. So few things to be noted as pigment dispersion on the endothelium, uneven anterior chamber depth, deep anterior chamber depth as compared to the fellow eye, presence of vitreous in the anterior chamber, then iridodonesis in patients of iris coloboma, iris atrophy, and presence of pseudoexfoliating material. As far as patients of trauma is concerned, look for traumatic mydriasis, iridolysis, and sphincter. Look for phacodonesis, folds of the capsule, lens tilt in the case, and again, the presence of pseudoexfoliating material on the lens capsule. Important to note is clockhouse of zonular thickness with the location and to assess whether it could be a progressive or static, which is going to tell us decide the plan of management, the surgical plan of management. Apart from looking at the slit lamp, it's a good idea to examine the patient in supine position, especially in patients with severe 360-degree zonular weakness, where in upright position, the lens may appear in the pupillary area, but in supine position, it may be actually in the anterior vitreous. Things to be monitored is IOP and fundus examination. So the few investigations can be done preoperatively. Coming to the surgical management, main indications would be visual symptoms, based IOP. Emergency procedure may have to be done in patients with lens in the anterior chamber, lens causing pupillary block, or lens which is tilted posteriorly in the vitreous, where there are high chances in subsequent time it may be get dislocated in the vitreous cavity. Goals of the surgery would be lens extraction, minimizing the vitreous loss during the surgery, clearing the vitreous from the anterior chamber, and most important being the stable IOL fixation. Coming to the management of dislocation of the lens, it is dislocated anteriorly, a limbal approach where lens is extracted from the anterior chamber, followed by the anterior vitrectomy. Because there won't be a capsular bag, we can go ahead with anterior chamber IOL, posterior fixation of the iris flaw lenses, and scleral fixated IOL. If it is dislocated in the vitreous cavity, a pars plana vitrectomy with lensectomy and scleral fixated IOL can be done, which can be either sutured, or a scleral. Now, depending upon the density of the lens may be disintegrated by the vitrectomy probe or a phacofragment. Coming to the management of the subluxated, whenever if there's a subluxation is more than 9 clock hours, it's is basically not able to, we won't be able to preserve the bag. So we can just go ahead and sacrifice the bag and go ahead with vitrectomy and lensectomy. For subluxation which are less than 8 to 9 clock hours, we can make use of various capsular support devices in following manner. For example, if the zonular dialysis is less than 3 clock hours, a single piece or a 3-piece iron can be positioned such that the haptics are placed in the area of zonular dialysis. Secondly, a patients with mild diffuse zonulopathy with zonular dialysis of up to 3 to 4 clock hours, which is non-progressive, as can be seen in the patients of blunt trauma. We can stabilize the bag with the help of a capsular tension ring, which comes in various sizes depending upon the axial length of the eyeball. The most commonly used being 30 millimeters. What this CTR does is it helps in forming the zonal anatomical barrier. So thus it prevents the vitreous herniation and misdirection of irrigating fluid during the intraoperative procedure, and also helps in redistributing the support from intact to weak area. It is usually inserted from the area of intact to non-intact zonules, either with the help of the injector, manually or suture guided. Now, timing of insertion, it can be inserted as early as after the hydro procedure or as late as before the implantation of the IOL. To further support, we can also make use of capsular hoops to reduce the further stress on the zonule while inserting the CTR. However, it is contraindicated when you have a back compromise in the form of PCR or if there is an irregular access. It's a clinical picture showing a CTR being inserted before the lens removal. For zonular dialysis, up to from 4 to 8 clock hours, a capsular tension segment ring, a tension segment can be used, or a Sionis ring with a single loop can be used. Now, capsular tension segment is nothing but a partial Sionis ring, which has got a short loop which is perpendicular to the segment with an eyelet, which can be sutured to the sclera. So it can be done with inserting the CTR previously for the equatorial support. This is a picture showing the capsular tension segment, and below by side is the capsular hoop. For zonular dialysis, up to 8 to 9 clock hours, or where the zonular weakness seems to be progressive, as in patients with pseudoexfoliation or patients with systemic anomalies like Marfan syndrome, a Sionis ring can be used to stabilize the capsular bag, which can be either one loop or short 2 loops, which are perpendicular to the CTR ring. Now, again, these are to be sutured to stabilize by the scleral fixation. This is a picture of CTR with one with a single loop and the other with 2 loops. This is a clinical picture. For cases of moderate to severe zonular weakness, we have a device as capsular. This device, as can be seen in the picture, has got a central rod which sits over the anterior capsular margin, and through the eyelet can be sutured to the sclera, where the 2 lateral arms goes below the anterior capsular margin. Now, this device needs to be inserted before the lens removal. However, disadvantage or limitations being this gives only the limited support only to the limited portion of the lens equator. So it can be used along with the CTR to provide the complete equatorial support. So all these devices to stabilize the bag can be used depending upon the cause of the dialysis. But whenever there is looking intraoperative maneuver, if there is extension of the zonula, both these things can be used complementary. Few surgical considerations as far as anesthesia is concerned. For children, general anesthesia would be preferred. In adults, it will be peribulbar prop if required sedation. Use of mannitol, intravenous mannitol for intermittent cataracts and eyes with shallow anterior chamber. Capsular stenting will be a good aid. Why? Because it is going to give the better visibility during the capsular axis. Also, it helps in increasing the elasticity of the capsule, especially in the pediatrics and the young adult patients. While performing capsulotomy, which is a very difficult part because we don't have counter traction by the zonule, especially in the areas of zonular dialysis, for cohesive OVDs would be preferred, which is going to flatten the anterior capsule. Ideal would be 5 millimeters size, initiated from the area of intact zonules. To aid, we can go ahead with bimanual rexis with the help of microforceps. A counter traction can be used once the nick is met with the help of a capsular or iris retractor. In pediatric cases, we can use vitreorexis. Patients undergoing femtosecond laser assisted, we can do laser assisted capsulotomies. As far as lens management is concerned, phacoemulsification with all the parameters with low, like that is low flow rate, low vacuum, and low infusion water. For the soft cataracts, we can go ahead and do phacoemulsification in the back, whereas for the hard cataracts, supracapricial emulsification can be done with minimal sculpting and rotation to prevent further zonular stress. For femtosecond laser assisted surgery, we have an advantage because the laser fragmentation is going to reduce the manipulation which is required before emulsification. While contact aspiration, circumferential stripping will be preferred over radial stripping. Once a bag is capsule is well supported by the various devices, the PCIL can be inserted in the bag. Few complications to be noted in intraoperative. Anytime it can cause worsening of the zonular dialysis, so we have to convert the procedure. There can be PCR or tear of the anterior capsule, loss of these capsular tension devices while inserting. Post-operatively, it can be CAB. When the zonulopathy is progressive, it can cause further zonular dialysis and decentration of the complete bag and the IOL and the chances of RD. Thank you.
Thank you, sir. It was very well illustrated lecture. Dr. Dheeraj, should we go to the next speaker? Dr. Dheeraj, you are still muted.
I think, sir, we can take the question answers at the end.
Okay.
We can start with the second talk.
Yes.
Yeah, it was a very nice discussion on the subluxury lens and management. Yeah, we invite Dr. Mona Sune ma'am to present the next case. Dr. Mona Sune has a vast clinical experience, and she's at present working in the. She's running the Sune Eye Hospital at Varda. May I invite Dr. Mona Sune ma'am, please?
Thank you so much. Good evening, everyone, and thank you, Vidarbha Ophthalmic Society, for this opportunity. Today, I am presenting the management of congenital cataract, and it includes early diagnosis and reference, screening and evaluation, surgical management, post-operative correction and rehabilitation, and comprehensive care. Evaluation of congenital cataract is critical in view of etiology and planning for the management for this. Detailed history of the maternal infections, antenatal infections like shots, and history of radiation should be asked. Birth history like low birth weight and history of any birth trauma should be asked, and family history of any eye problem should be asked. Then ocular examination includes ray reflexes, see the opacity in the visual axis. Visual acuity should be tested using age-appropriate testing. Biomicroscopy should be done to assess the severity and morphology of the cataract and associated abnormalities of cornea and the anterior segment. Examination of the sibling and parents should also be done to rule out any familial cataract. Ophthalmoscopy for detailed retinal examination to rule out if there is persistent fetal vasculature or any retinal detachment. And these scans should be done in case of a dense cataract. And then this is the these are the various morphological appearances of congenital cataract based on the location and pattern of the opacity, which can help to decide the operative plan and prediction of the visual outcome. Then systemic and genetic evaluation in case of congenital cataract. Bilateral cataract without family history definitely needs evaluation. Lab workup includes short test for toxoplasmosis, rubella, cytomegalo, and varicella viruses. VDRL test for the syphilis should be done. And blood test for the calcium, phosphorus, glucose, galactokinase, kinase, and the RBC transferase level should be done to rule out the metabolic cause. Urine test should be done for the reducing sugar and imaging in case of a neurological issue. Genetic testing like next generation sequencing gives us 75% precision in the familial cataract and 63% precision in the syndromic cataract, and possible to check all genes involved in congenital cataract from one blood sample. The thorough pediatric examination should also be done to rule out any congenital abnormalities and syndromic association. Then factors to be considered in congenital cataract are amblyopia, fellow eye condition and refraction, assumed compliance, and parental refractive error. Indication of surgery are dense cataract blocking red reflex before the dilatation of pupil, abnormal visual behavior, strabismus in unilateral cataract, nystagmus in bilateral cataract, unilateral cataract with depth-corrected visual acuity less than the 20/50. Partial density cataract less than 3 millimeters can be observed. Then, timing of the surgery. In congenital cataract, surgery should be done before the critical period to avoid the risk of amblyopia. In unilateral dense cataract, it should be done on or before 6 weeks. And in bilateral cataract, it should be done around 8 to 10 weeks. Consider immediate sequential cataract surgery in case of bilateral cataract if the child has any other systemic problems to avoid general anesthesia twice with, of course, utmost care as there is a risk of endophthalmitis. This for the primary IOL implantation was always a controversy, but nowadays all pediatric ophthalmologists practices for primary IOL implantation at the age of 6 months, where the corneal diameter should be 9 or more millimeters. Preferred age for secondary IOL, as we all know, is around 2 years before the school. Then biometry is very important in congenital cataract. The keratometry preferably should be done without a speculum. Axial length is measured with test and ultrasound, with the immersion method being more accurate, and it has to be done mostly under GA in younger children. Optical biometry is possible if the child is older and cooperative and the cataract is less dense. Then commonly used IOL formulas are third generation theoretical formulas, and the preferred ones are SRCP and Holiday 1 in children. And then newer formulas like Barrett Universal 2, EVO20, Hill RBF.O, and Kane are also showing superior predictability. The target refraction is aimed at for initial hypermetropia, high or low, or emmetropia according to the age at surgery. And why to aim for hyperopia? As we all know, eye is growing continuously at an early age, and there is a chances of high myopia in adulthood, that is myopic shift, and that's why our aim is for low to moderate hyperopia post-surgery. Many of us follow the under-correction rule for IOL to put child is less than 2 years, a 20% reduction in the IOL power is done, and if the child is 2 to 8 years, then 10% reduction in the IOL power is done. Many follow the rule of 7. It is nothing but the sum of the age in years and the target refraction. And this table shows the age of cataract surgery and the residual refraction recommended. For example, at the age of 6 to 12 months, the residual refraction should be plus 6 to plus 10 diopter, and so on. Coming to operative techniques. Commonly used surgical approach is clear corneal or scleral tunnel with the aspiration of the lens with posterior capsular exchange with limited anterior vitrectomy with or without primary IOL implantation. A minority of surgeons still opt for the pars plana approach. Then the posterior chamber IOL inserted into the capsular bag is preferred one. Similarly, focus placement of a foldable acrylic or a single piece rigid IOL can be done if needed. In case of no capsular support, posterior chamber IOL can be seen in the place. The placement of iris claw or affixated lenses is becoming popular nowadays. Then single piece acrylic hydrophobic lens with preferably heparin coating is preferred. All but the smallest watertight incisions should be closed in children with a synthetic absorbable tendosuture. These are the suitable sites for the secondary IOL implantation. Of course, the presence of capsular bag, capsular support and the exchange decide the site of the implantation. Then follow-up is very, very important in case of congenital cataract, as in case of during the changing refraction, amblyopia, visual axis capacitification, and glaucoma. Rehabilitation is essential in view of residual refractive errors and the development of outline. Can be done with the contact lenses or glasses. In case of aphakia, refraction should be given within the first week of aphakia, and in case of pseudophakia, it should be given within the 4 weeks of pseudophakia of residual refractive error. Infants and toddlers should be done myopic of -2 diopters, and at the age of 2 to 3 years, the child may need for a near correction also, so you have to prescribe for a bifocal. Even spectacles with the aphakic correction are mostly well tolerated in bilateral aphakic infants and children. Contact lenses are mostly given in aphakia planned for a very young infants and after lensectomy, and they can also be given in the pseudophakia for a residual refractive error. Then common complications are visual axis opacification and require surgical removal from 3 months to 1 year after the initial surgery. Younger the age, more the chances of glaucoma, and you have to follow up for it for many years. Then management of amblyopia is very important as it is common in the unilateral cataract. It can occur in bilateral symmetric cataract too, asymmetric cataract too. Patching of the sound eye is the mainstay of the treatment. In bilateral aphakic eyes with contact lenses, the contact lens of the dominant eye can be removed for few hours or several days per week as with unilateral structure. Then we aim for an optimum quality of life in a limited visual capacity. Thank you.
That's a great and complete presentation on the management of our congenital cataract, ma'am. Thank you so much. May I request Dr. Neha, ma'am, to please proceed further, ma'am.
I think Dr. Ragini Parak madam has not joined us. So let's, I think Dr. Vavikar sir can be, we can take his lecture. So I'll introduce Dr. Vavikar sir. Actually, he doesn't need any introduction. He is into private practice for last 22 years and he has a big institute for training young ophthalmologists for refractive surgery and cataract surgery. He is not just a teacher, he's also a lifelong learner and he has traveled world for his learning. He has been the first one to perform the bladeless cataract surgery in India, and he is going to talk today about multifocal IOL workup. Sir, over to you.
Can you hear me now?
Yes, sir.
Good evening, everybody. Thank you, VOS, and thank you, Dr. Neha, for the kind words. So I'm going to talk on multifocal IOL workup. Now, today's scenario is that patient always wants more from us. Okay, cataract is considered as refractive surgery, and therefore sometimes there is a mismatch between what we want, what we promise, and what we deliver, or what patient wanted and what we deliver. And therefore, it is very important that we go into the detail, especially after the area of COVID. It has happened that patient want more and more, and more patients are going for trifocal IOL. So we start with the workup, basic workup. And there I would like to do with PVM. We are going to talk about trifocal workup only mainly, but potential visual acumetry, because many times there is a mismatch between the degree of cataract and drop in the vision. And therefore, unless and if we do potential visual acumetry, diseases like amblyopia can be missed. Then we talk about Varion, that is the K readings, IOL master, and tomography, pupil size, MGD, and IOP. Now let us go to all these one by one. So we start with astigmatism. It is very important what garbage in is equal to garbage out. So if we do not measure and manage the astigmatism properly, we are in for some serious trouble. There are many ways astigmatism can be measured. There are many keratometers, but what we do nowadays is dynamic keratometry. That means a short video is taken and the machine only picks up the best reading. This way we are avoiding many errors like patient not fixing properly, or dryness issue also is reduced to a certain extent, even though dryness is an important thing. Keratometry has to be done on a virgin eye. That means without touching the eye on that day or without putting any drops. If the patient has dryness, it has to be treated in advance. Everything, the patient chin and head position, tilting of the head, rotation of the head, where the patient is going to fix, especially if it is a mature cataract or patient is amblyopic, squint, everything needs to be taken into consideration. And then take 3 readings. What we do is that take 3 readings from 3 different machines, okay, or at least 2 different machines, and match them. So grade 2, that is extremely right hand side, that all the readings are within 0.1 diopter of each other and within 5 degrees of each other. If this is the case, that means it's a regular cornea, and you go with any K reading, you are going to be bang on target. Whereas sometimes there is a partial matching. That means the dioptric difference between the various readings is between 0.1 to 0.25. And the axis variation is between 5 to 10. Then go for Barrett's median K or Barrett's integrated K. This is a fantastic tool developed by Barrett where we put in all the K readings of different machines and he will tell us what K readings to use. And then if there is absolutely no matching at all, that means the axis as well as the power is greater, best is to go for manual keratometry. Then we go for IOL master. Again, very important thing, IOL master. I'm sorry. Okay. Previously, we used to say that, 53% of the patients we used to be within plus or minus 0.5. But after Barrett, EVO, Kane, and all these formulae have come, we are very well in a very good range, 90% or sometimes even more patients where we are within plus or minus 0.5. And the residual cylinder has to be, also we have managed to get below 0.5. Then there is also a concept of micromanovision. That is, it comes as a saving grace. That means you do a trifocal, multifocal IOL, and after 4 or 5 days, when the corneal wound edema subsides, you do a refraction. If the patient is left with slight hyperopia, in the second eye, you adjust the IOL power accordingly, or myopia, and the same thing. So it gives us increased range of vision, and patient does not complain that he cannot see distance of far. You remember, if the patient has got minus 0.25 with a 0.5 cylinder, he will not have very good vision beyond 4 meters, and that can be disturbing, especially, patient has got lot of night vision problem. Then we come to formulae. There are many formulae now, and what we do at our place is that we use 3 different formulae from 3 different ways they are derived. So usually we go for one version formula and we have Barrett there, and we go from ray tracing, we go to Robert, and then EVO, because EVO has got the maximum rate of hypermetropia. Emmetropia. And suppose there is a tie, then we go do the calculation with Hill RBF3, and many times we get a very good reading. Now, this is a chart which shows which formulae are the best, okay, which give us maximum. So in that, again, you see the Barrett and the EVO and the K, the Robert are the best one. And then same chart is there for, this is for abnormal eyes. That means non-version, post-myopic, post-hyperopic, and etc. Notable point to say that post-RK is the least, satisfactory area even today. Even in long and ultra long and short eyes, we have to be very careful what formula to use. Another important point you have to see is why we are not reaching 100%, because there are so many errors which we are introducing, and we need to get rid of these errors. So like starting from using a single formula, because there is an interformula variability. Then patient cooperation, as I told you, if the patient has got mature cataract, he will not be looking directly at this, fixation target. And therefore, IOL master comes into play, whether we see whether the ray of light is passing through the macrofoveal pit or not. Then using suboptimal device and calibration issues are there, typo errors are there, post-refractive surgery, post-refractive surgery is not entered, then biometry is not measured properly. There are, even if we say that most of the machines are operator independent, that is not so. We have to be very careful. Then there are using outdated formulas. Now, nowadays, nobody is going to use anything previous than SRKT. SRKT, by the way, is a very good formula if it is optimized and if we have Bangkok modification done to that. Ocular surface, this is an important cause. So there are so many causes, and if we work on these causes one by one, I'm sure all of us will get a good reading. Now here is a one patient where all the 4 formulae are showing 23.5 diopters, but that is not always the case. And therefore, we have to be very careful about what we are doing. Now, this is a patient where one eye is showing 22.5, other eye is showing 21. And unless and until we justify the difference between the IOL powers, we should not go ahead. Who knows the eye with 22.5 diopters may be amblyopic and patient may not get optimal vision, or other way around, the patient with the IOL power of 20.5, he has got a refractive error of 1 to 1.5 minus. Then there is in hypermetropia, we always get this surprise. You see that Barrett 24 diopter, Evo 25, Kane 25.5, and therefore RBF came as a Hill RBF came as a tiebreaker, and we landed up getting 25 diopters, and we were bang on target. So if we had gone directly by Barrett or on Kane, we would have been for a refractive surprise. APSCRS or ASCRS, these are excellent website when you are dealing with post-refractive surgery. It not only gives you average, but it also gives you, weighted average, but by each formula, how much you will get. Then we go to tomography. In tomography, first see whether it's a normal cornea, regular tomography or not. Epithelium has become very, very important. For cataract, most important part about epithelium is dryness. If the epithelium is irregular, we are in for trouble. We are not going to get accurate readings. Epithelium does contribute to higher order aberrations. Epithelium does contribute to some amount of refractive error, and we have to be sure. Then you can see the claw over here, crabs. The regularity becomes important. Then angle alpha and kappa. Angle alpha, more important for us. The simple principle that the centermost part of the eye, the bull's eye of the multifocal IOL, if the diameter is say 1 millimeter, you cannot have an angle alpha more than 0.5. Otherwise, the ray will pass from outside this bull's eye and patient will have really poor vision. Then we go to pupil size. Again, we say that patient, the IOLs are pupillary independent, but that is not particularly so. Nowadays, we are getting younger patient developing cataract. They have big pupil size, and many times at night, when the pupil expands beyond 5.5, they are unhappy with all these IOLs. Even with EDOF, they are sometimes unhappy. And very old patient, when the pupil becomes small, if the pupil is less than the smallest ring, then the lens is going to act like a monofocal lens. MGD is another important menace. MGD has the capacity to spoil otherwise an excellent done surgery. So treat beforehand. Important is that counseling the patient. Post-op regime, dry eye, we have different regime for patient with dry eye as compared to normal patient. And if the post-op treatment is required, patient is mentally prepared. Now, here are two examples. You can see that this patient, the blink is quite okay, whereas in this eye, the blink is abnormal. In this, here the tear meniscus height is low, but whereas here the tear meniscus is quite normal. Over here, the secretions are low, but comparatively high. And you see the MGD loss is different. So every patient is different and we have to treat accordingly. Then we go to dilated fundus examination. Sorry. So before you go to dilated fundus examination, it is very important to see how much the HOA patient has. And we have a habit of checking the patient's higher order aberrations at a 3 millimeter pupil. And you can see that once you make it 6 millimeter, suddenly the HOA increases, because we know that HOA is a peripheral corneal phenomena. And this patient, he has got RMS of 0.85, is certainly not a very good candidate, especially if the patient has got high amount of vertical comma. Horizontal comma tolerance is better than vertical comma. Similarly, spherical aberration, the tolerance is slightly better. So we have to understand even in HOA, what kind of HOA patient is having. One second. Yeah. Fundus examination. So many times we have a situation where, the PVM is not 20 by 20, or there is a pigment mottling on the macula and we don't know whether this is normal or not. Probably the disc is also looking suspicious, and that is where comes the role of OCD. Even if we are anterior segment surgeon, it is high time that we understand the ellipsoid and myoid zone and whether there is any loss. And we will be very, very surprised to see that very subtle signs are found many times. Now you can see that this patient has a PED. I hope you can see my cursor, a small PED, and it is such a small thing that it can be missed, but it can make a multifocal IOL patient really unhappy. Similarly, there is a patient, you can see that there is a subtle diabetic edema, and this needs to be treated. Otherwise, postoperatively, this will increase, and we'll have, to answer 1,000 questions on that patient. You can see that there is a very subtle ERM. This ERM can progress later on rapidly, causing significant drop in contrast sensitivity, and patient is going to be, or metamorphosis, and patient is going to be unhappy. And therefore, it is very, very important that we do trifocal workup properly. Now, I've got more presentation regarding multifocal, but I think I'll stop here. If there are any questions, I'll be more than happy to answer.
Thank you, sir. It was extensive and very, very nice presentation. But I think Dr. Ragini Parekh madam has joined us. Dr. Rahul?
Yes.
She has joined.
Yeah.
So
Welcome, madam.
I'll just introduce her. She doesn't need any introduction. I think everyone in India knows her. She has more than 80,000 surgeries to her credit, numerous scams, including operating on a leprosy patients in Anandvan, which I was fortunate to see. I have seen Dr. T.P. Lahane and her working as a well-oiled machine and conducting camps smoothly. There are
But
so
not
many
see,
awards.
Neha,
to
you
her
have
credit.
worked very hard in the camps also with us. And
Thank
so
you.
that's Smita Didi, and Vavi is my first teacher. He was my senior, and I rag him and bully him a lot, but he's my first teacher. And he would shout at me if I didn't suture well. So he taught me surgery. And hello to everybody. Thank you, Dr.
Hello, hi.
Thank you, Viral. Hi, Durgesh. Namaskar, Otswal sir. Namaskar, everybody. Thank you for the invitation.
So, madam, you can now take this further.
Yes, I'll just, we can. So actually, it is going to be like this, that, my presentation and his are going to be coinciding. I'll just share my presentation. Just a minute. नाही हे शेअर करायचं आहे. यू आर स्क्रीन शेअरिंग पर यहाँ से ना
स्क्रीन से वो वाला कट
ते कट नाही होत अलाव
वरून कट काय म्हणतात की हा ठीक आहे
अलाव
हा
can you see my screen? Yeah, okay.
Yes.
Can they hear me?
Yes, we can hear you.
You're audible and visible, everything good.
Thank you, Didi. Yes. So ये एक छोटा कर देते हैं इधर सो नहीं ये हाँ okay. So
शुरू करना
हाँ मैं करती हूँ. Yeah. So I think Vavi's talk and my talks are going to just a minute. Yeah. So Vavi's talk and my talk are going to overlap a little bit. So this has to go forward. Ready? Sir?
You will have to click that arrow at the left side bottom to progress.
Yeah, this one. Yeah. Thanks. So basically, when we started intraocular lenses, now it is a cataract refractive surgery. So IOLs made for provision of spectacle-free emmetropia for distance and near. Okay, so we have so many IOLs, right? You have trifocals, you have accommodative, you have multifocal, you have toric IOLs, right? So what we need to see is when to, Vavi has already said ki when to do this and when not to do this. So I'll take this same route. So basically, for any patient, when before you choose whichever IOL you want to do, then you have to have a pre-operative checklist. I don't know, I think it's going to overlap with Vavi, but basically, whenever you are doing any intraocular lens, the patient has lots of expectations. So you have to check whether there is any measurement errors. So what we believe in is that there is at least one reading that we do take ourselves, you know. So that is extremely important. Then IOL calculation. So that is what we believe, that the IOL calculation, our one reading is important by ourselves. And so you have to decide where the IOL is going to be, what is the post-operative refraction, what is the measurement. So previously it was like this, you take a A-scan machine and you do it. But now there are lots of parameters. Then after that is you have to sit and discuss with the patient what are his needs, that what type of IOL you are going to use. Now, after that, and even before that, you have to decide what the patient has, what is the ocular structure that the patient has, whether there is anything in the cornea, whether there is anything in the retina. So I think this has all been discussed, but I think there is no harm in stressing it again and again. So, you know, if you first we used to just do a scan or now if you're doing a premium lens, then topopachy is extremely important, because if you have a cylinder especially, then I know a patient who was operated, a piggyback IOL was put because the patient had astigmatism. They did not bother to do a topopachy. The patient came to us, he was a very, very big hasti, and we found that the patient had keratoconus and he was 70 years old. So it can happen at any age, even after a second surgery. So whenever you have aberrant readings or high keratometry readings, especially in high keratometry readings, then you have to rule out corneal pathology, corneal opacity, aborted ectasia. So it is a must in diseased cornea, and not only in premium IOLs, but if you have the time and facility, for all. Dry eye evaluation. So dry eye is prone to give false keratometry readings. Now, my father has Sjogren's and chronic dry eyes. Very simple method. This I was talking some days back at a WOS meeting also, that you can do lots of tests like meibography, which is being seen, and other tests. But very simple, very simple. Whenever I put a patient on an autorefractometer, the Myers are irregular. In any autorefractometer, you see concentric circles. But if they are wavy, or if they break up and they become wavy, like with a blink, that means the patient has dry eyes. You don't need fancy machines, so your readings are going to be aberrant. So many a times we repeat patients' readings, and dry eye readings, the patient will have astigmatism. Even if a patient just rubs the eye and comes for keratometry for, say, IOL Master 700, then you get aberrant readings. So you have to tell the patient not to rub the eye, to put artificial tears, to make the patient wait. See to it that there is no dryness. There will be false readings if you have. So there are so many times when I suspect dryness, and I tell all the optometrists that if you see that the Myers are not concentric in any patient, even if it is OPD, not only cataract, do call me. Let me see what is happening on the autoref. And of course, the Schirmer's test is the most simplest, especially in women, menopausal, arthritic, and now so much of our OPD, because like young cataracts, and most of them, if whatever pathology they come with, because of the misuse of devices, we are seeing Schirmer's with 1 millimeter, 2 millimeter. So in the future, you are going to have patients with severe dry eyes. And I have seen patients where very good surgery has been done by the other doctor, but because of severe dry eyes, the patient is extremely unhappy. And how can you catch it post-operative? The patient will say, khatakta hai. something is not happy. So post-operative, you may think that the patient is 6/6, but the patient will be unhappy. So this is very important. Vavi was talking about OCT macula, so I think I will not repeat it, because you will have a very unhappy patient if you have not seen the retina. If the retina is not visible because of the cataract, then you have to warn the patient that I cannot see and I do not know what the results are. So pre-operative counseling, I myself, even today, spend a lot of time with the patient, know the patient. Last month, I refused a patient because she was adamant that I have to drive in Canada. If you're giving me a bifocal lens, then why would I read reading glasses? And I don't want halos with trifocal. And why are you not going for multifocal? You won't believe it. We refused the patient because I knew that nobody could make this patient happy. So counseling and knowing the patient's personality is extremely important before putting a lens. So do not promise the sky. Then this is one example with bilateral posterior subcapsular cataract and 618 vision. The patient wants a trifocal lens for spectacle independence. Now we say that we cannot guarantee spectacle free vision. The patient had normal topography, normal OCT, and normal IOL calculation, right? So here you can see normal vitals, everything was normal. So everything is important to be checked, right? So you go ahead with this. But what happened to the patient was that when you did the meibography, the tear breakup time and the Schirmer's test was less. Now, I was just telling you that these young patients with digital misuse and all that are coming up with such things. And though everything was normal, blood was normal, everything was normal, if you see this condition, then you have to wait to treat the primary condition first, because dry eye symptoms are going to be exaggerated post-surgery. The patient is going to be unhappy. Now, many a times what happens is that you miss the dry eyes pre-operatively. And like I told you that it is very simple not to miss the dry eyes before surgery. If you see so many particulate matter, the patient is uncomfortable, the patient is not allowing you to examine, then you should not miss it. So as you can see the meibomianitis, you can see everything. So you cannot miss this diagnosis. Intraoperatively, increase surgical time, incision size, and lens hardness. So this also can affect. They cause inflammation, which again causes a reduction in the goblet cell. So we don't pay attention to this, that, this may cause damage. Post-operatively, we are using a lot of drops because we are very, very important. So a patient who has borderline dry eyes will go into dry eyes because of the post-operative drops. So this is a second example of a 55-year-old male with bilateral nuclear sclerosis, hypertension, diabetes, bypass, and wants spectacle-free vision. So normal topography, normal IOL power, but patient has normal blood test, but the patient has proliferative diabetic retinopathy and non-proliferative diabetic retinopathy, one in each eye. So, till last year, we didn't even have a fundus camera, but I feel that of course the expenditure is very high, but either you can share or get it done. These are now becoming so important for us to explain to the patient that what we are seeing and what the patient has. So this makes our life very easy to explain to the patient that these are hemorrhages, this is macular edema, and therefore if you have anything which is affecting the macula, so premium lenses will be here contraindicated. You have a patient with right eye nuclear grade 3 cataract, left eye pseudopacia, and one spectacle free vision. 1 point, so you do the Barrett's calculator and you see the astigmatism. Again, you have taken all the checkpoints, IOL calculation, IOL corneal pathology, retinal pathology, and you have a central irregular cornea. So if you have something like this, the patient is going to be unhappy. So sometimes, you feel that the operating time of a cataract patient is only 10 minutes, but the workup is bigger, and it should be bigger if you want to avoid an unhappy patient. So that is extremely important. because you don't want to have a unhappy patient if you are doing a toric IOL in this patient. So you have to be very, very careful. So, you feel that everybody is doing multifocal IOL, toric IOLs, this, that, and the other. But before doing it, so if you are going, and on top of it, what has happened is that these lenses are much more expensive than the monofocals that we were using. So Indian patient mentality is कि हम इतना खर्चा कर रहे हैं, हमको उतना बदला मिलना चाहिए, हमको इतना vision आना ही चाहिए. So that expectations are very, very high. Then you have another patient with grade 1 cataract, wants spectacle-free vision, and he's likely to play sports. And he, now these rave parties and all that. So everything, you have a checklist over here. You have continued the checklist, but here everything is normal. But this patient is young. He has unrealistic patient expectations and type A personality. I'll tell you, this is what we avoided. This patient, young patient, is acting in ads. She stays in Canada 6 months in a year. She's a doctor's relative. And she said that my friend has monofocal, I want monofocal. If I'm spending so much money, 1 lakh for a lens or more, then I should have 100% vision. There should be no halos. If it is bifocal, why bifocal? I should see near vision. So she kept on questioning after 3 sittings, 4 sittings with a doctor standby. Then I called up the doctor and said, see, I really cannot do it because I cannot please this patient. You won't believe it. It was a doctor's bhabhi, but we still refused the surgery because I knew that this patient can never be made happy. Because it is human tissue. You cannot guarantee कि 0.5 cylinder nahi hoga, even if it is a panoptics or a trifocal lens, because human tissue behaves differently. Healing behaves differently. So you have to be careful. Now, a 60-year-old male with nuclear grade 2 cataract wants spectacle-free vision, and he is already a case of high myopia. So as you can see, the IOL power is 6.5 and OS and 10 in the other eye. So you know that the patient is very, very high myopic. Now, as you can see, the patient, because he's extremely high myopic, you can see the chorioretinal degeneration with scarring in this patient. So the macular pathology patients have more reduction of contrast sensitivity. So they do not achieve expected vision, right? So basically what it means is that, of course, premium IOLs are the future of cataract surgery. But the most important thing is that there are 2 aspects. One is the financial aspect, where Indian or imported, the patient has very high expectations because they are spending more money. That's the only thing that they have in their mind. And they want gratifying results because these patients have listened to so much. They are the WhatsApp, what is called encyclopedia, where they come with everything, ki spectacle free, ye nahi hona chahiye, wo nahi hona chahiye. So you have to, it is very, very difficult to manage an unhappy patient. And this unhappy patient will spread more information than a happy patient to all the people who talk to him or visit him. So you have to promise less and deliver more. So basically, that is extremely important. I think Vavi's presentation was even more vast, and I think our presentations did overlap. But my presentation was which IOL, when and how and what workup should be done. So I think we used to do a basic vision, slit lamp, tonometry, IOL calculation, and that's it. Now it has advanced to cornea evaluation, OCT evaluation, dry eyes, AS OCTs, topography and pachymetry. But I think that our fundus photography, I think, but we should not shy away from these things. Finance is a major factor, because to own these machines like meibography, which I saw one of Vavi's beautiful patients, and he's so happy that meibography was done. So it's very easy to explain to the patient what the patient has. So these machines cost more than 1 or 2 crore rupees. So it is going to be very difficult. But at the same time, I think in Mumbai or in Nagpur, there are centers which pool or offer open house services. So we should not shy away from doing all these tests to give the patient the best results. I want to thank again, I want to thank all of you again for inviting me here, allowing me to talk and spend some time with you. Thank you, Rahul, especially for the kind invite, and I'm really
Thank you, madam.
Thank you for joining, madam.
Madam, yes, Madam Lane sir is there. We want to see him.
Lahane sir is there.
Sir, if you sir can give a 1 minute blessings to all
No,
of us.
Lahane sir got the computer. This
Okay.
presentation is in his computer. He
Okay.
did everything with the Zoom meeting. Poor thing, I'm making him trouble. Sir, they want to see you. Everybody
Sir,
wants to meet you.
Sir, 1 minute की blessings दे दिया. Welcome, sir. Welcome.
Hi.
Welcome.
Good evening,
Yes, sir.
all.
Hello, sir.
Everything
good
excellent
evening.
excellent going on. I am very happy that the MOS is doing excellent work. I congratulate each and every member of MOS, and I am very happy and proud of VOS. Yes. So I am very happy for that. VOS.
Thank you, sir. Thank you.
Thank
Thank
you
you,
very
sir.
much.
Sir,
Thank you, sir.
Lane sir. Yes, sir. This is our golden jubilee year. We are now in 50th year.
Yes,
And we are
that is
going
in
to.
now January you are doing it,
Yes, yes, sir.
Yes, sir.
You will be there.
Yes, sir. Thank you, sir.
Thank you.
So
Thank you.
over to moderators for further discussion.
Thank you, sir. So I would like to ask all the panelists to, do they have any questions? Yes, Dr. Rahul, please go ahead.
Yeah, I want to ask Vavikar sir. In the current scenario, which is the best optical biometer according to you?
So, but am I allowed to take company sites?
Yes, sir.
Rather than take company side, you can share your experience. That will be very helpful for us.
So I am personally using IOLmaster 700 and it is really good. But I had taken a demo of Argos and I think Argos is like one generation ahead of the most important point about Argos that it gives all the benefits of IOLmaster, but IOLmaster takes around 30-40 seconds to take a reading entire, whereas Argos does everything in 5 to 7 seconds. And therefore, many times before the tear breaks up, all your readings are done. Like you can actually say within blink of an eye. And the accuracy of both the machines is equally same. Equally good.
Okay.
Then what are they quoting for Argos? Sir,
What?
for Argos, what are they quoting, sir?
What are the?
I don't
Quoting
know.
price.
I
Price.
don't see.
45 lakhs. They're quoting 45 lakhs, sir.
Okay.
I am already having IOLmaster. There is no they are buying.
So even we are using IOLmaster 700, and the thing is, you know what? IOLmaster 700, like Vavi said, but even then we take 1 or 2 readings to be consistent at different times, like my optometrist take and I take. And the thing is that you have to also use the correct formula in that. So we are using the Barrett calculator. So that is also extremely important, So like Vavi said that, it's a very, very satisfying machine, but you have to be careful. You have to ask the patient to blink in between 1, 2, and 3, so that there is no dryness. What he's saying is absolutely correct.
I think the Tommy machine also, there's optical biometer which works very well in very dense cataracts also. So that is one lower end option. Though IOLmaster is definitely much better. So
No, Smita, you are very right because, you have to afford so many lakhs. There may be students, there are people who are just beginning, so they have to know. You just can't say that you have to have a certain amount of crores to start a practice. So that is also very, very true. Your point is really has to be very well taken, It is becoming.
So,
To
Tommy
ask all
machine
the speakers about for the IOL power calculation, why do we really need in every multifocal patients like this dynamic keratometry we discussed or the ray tracing mechanism we discussed? So do we need it in every multifocal patient? See, fundus examination, maybe certain extent, if you suspect anything, OCT, maybe topography may be needed, but ray tracing, dynamic keratometry, all these things, do we need in every multifocal patient?
No, you don't require. See, basically, if you have at least one higher machine, like we are talking about IOLMaster 700, the keratometry of IOLMaster 700 is really, it's like gold standard. And if you compare it even with manual keratometry or a simple device, which gives you keratometry at a diameter of less than 3 millimeters, you can really get a good idea about what we are dealing. Even topography will let you know whether the SIMKs are good or not. Of course, SIMK are not as good as actual keratometry because it is called a SIMK, right? Simulated. But it does give you an idea whether we are on the right path or not. So it is not necessary. And ray tracing is really not necessary. See, basically, everything is available on internet. So if you are sure about your K reading and axial length, okay, and if you use two formulas, let's say EVO is available on internet, Robert is available on internet, Hill RBF is available on internet, and Barrett. Now, if you use even two formulae, there are times that you will definitely understand that the IOL power, there is a difference between the two IOL powers, and sometimes a difference of 0.5 can get converted to 1 diopter on actually on the clinically. So that's why very important that you use two formulae rather than insisting on ray tracing.
Dr. Durgesh Pashit.
So for this post-refractive surgery patients, I feel that topography becomes mandatory for calculating IOL path, but otherwise, other patients, I don't think it's mandatory, but for post-refractive surgery patients, I think topography is essential because those readings are required for calculation. So
Actually, no, topography now is mandatory for toric IOL, as like Dr. Ragini shared an example where the patient has keratoconus and whatever you do, patient is not going to be zero on astigmatism. Similarly, if you have a multifocal IOL patient, you definitely require topography. We had a patient where patient had an unexplained amount of astigmatism. Okay, in one eye only, and we were trying to understand. Now, when we did topo, we realized that one nasal side is actually very, very flat. And when we examined the patient on slit lamp, there was a very, very slight hint that patient has undergone pterygium surgery. Okay, the surgery was done very beautifully, but that became our problem because it was very difficult to pick up. Now, when I asked the patient in detail, she said, yeah, when I was in college, 30, 40 years back, I had undergone some surgery on that. And she had completely forgotten about it. So topography does make a difference. Besides EBMD, many times we pick up on topography. EBMD, Salzman nodular degeneration, you can see an isolated area where there is elevation. So the dryness you can pick up on topography. So even if you don't have tomography, epithelial mapping, etc., basic topography is a must when you are doing multifocal IOL or a toric IOL.
I think Dr. Pashine has to ask something.
The audio is not.
Yeah.
You cannot hear. No, your audio is not.
Anybody who is asking question? I'm not.
Durgesh Pashit.
No.
Durgesh, I think you should leave the meeting and rejoin with the audio on.
Meanwhile, sir, if the patient, you were saying that the dry eye patient is there, and it will cause a lot of uh, uh, changes in the keratometry, and these patients are not right to plan for the multifocal. So in these patients, what is your protocol? Like, you will treat for certain period of time, and then how long will you treat, and what will be the cutoff? Maybe say for that matter, a Shermer's value or something, when you will take the keratometry and then you plan a surgery, or you at all will not go for a multifocal only for these patients?
It's a very, very good question. See, first thing is that we try to understand what is the cause of dry eyes. Okay. If it is because of something like ACLE, rheumatoid arthritis, it is going to worsen over a period of time, and that becomes a relatively absolute contraindication for trifocal. If the patient is working on computer a lot and that is the cause of dryness, but patient is driving, patient is really fond of driving, again it becomes a really important cause to deny trifocal IOL. But on the contrary, if the patient has got dryness, okay, and she is a housewife, homebound, does not go out at night, see, trifocal lenses, they work very well in room light conditions. And we give treatment, and with like a really small treatment, ladies tend to have more MGD after the age of 45. So you give treatment of MGD, and if you realize the patient is really doing well within 15 days, okay, we can go ahead with trifocal. So it depends on the profile of the patient. And nowadays, whenever we are in doubt, we have EDOF lenses, and therefore we can always give the patient, you are having dry eye and blah, blah, blah. So this is a safer option, but only thing is that you will may have to require slight number for reading. And the number is so small that only fine print is not being read. Many times you'll realize that they don't require to read fine print. So whenever I put lenses like Extend or VVT, patients say that I've given them +1, but patients that have forgotten the glasses because such a small print, hardly anybody has to read nowadays. So we have patients of dry eye where we don't do at all, or we go ahead with trifocal, and we can think of EDOF eye also.
Right, Dr. Durgesh, are you going to
Sir,
ask
sir, yes,
something?
sir. Just in case of, sir, suppose very dissatisfied patient of multifocal, when do you consider for IL exchange, or do you consider it or not?
No.
Can you hear me, sir?
If what is the cause of dissatisfied patient is important. If the patient is left with, say, one diopter, okay, surprise, then obviously you have to do something about it, right? If the patient
Yes.
has 0.75 cylinder, then as the corneal wound heals, it is possible that the cylinder can decrease below 0.5 or even 0.5. Patient may be unhappy. If the patient has got other causes of dissatisfaction, like dryness and corneal edema or fuchs corneal guttate or decentered IOL, mild PCO, macular edema, epiretinal membrane, very bad amount of vitreous floaters, then they need to treat according to the cause, not IOL exchange.
Suppose, sir, a patient is having only problem with glare and halos. Otherwise, he is okay. Every anatomy is okay with thing. See, most of the times, these patients, dissatisfied patients, no, we cannot find the equivalence of actual pathology in these patients.
But
They are only dissatisfied. They even don't. They cannot explain the what problem they are having. They only complain about low vision. दिखता नहीं है, दिखता नहीं है. Only they even cannot explain their vision properly.
So again, that's a very good question. See, first thing is that, I will do pupillography, angle alpha, higher abrasions of this patient. A patient has to do really well, score well on these points. I will see what his profession is. Suppose he's a taxi driver and you put trifocal oil and you tell him that you're going to, 3 months you have to sit at home, he's going to get angry on you. Okay. Then while counseling, you give them two options. Number one is EDOF when there are no halos and glares, and trifocal when there are halos and glare, but with trifocal no reading glasses, and with EDOF very minor reading. Many times I have seen that ladies gravitate for trifocal, whereas corporate people they gravitate for EDOF. Now, once options are given, patient cannot say that you never told me about this thing. Okay. And if the lens placement is proper, okay, there is very, very less chance that you will have to remove the IOL. So if we go systematically, proper examination, proper counseling, giving two options. Like one of the important things about dry or MGD is that once you have given the treatment before surgery, if you have to give treatment again, patient knows that this problem was there from before surgery. Then he does not blame surgery. So similarly, if we give two options, with rings, without rings, then very unlikely that the patient is going to be unhappy. Nowadays, actually, the amount of dissatisfaction with trifocals has gone down considerably. See, if the patient...
Even I feel, sir, even my experience is the same.
Correct.
Our Indian patients are very tolerant.
And see, if the patient has got minus 0.25 in both eyes, okay, minus 0.25 means focus at 4 meters. Just imagine he is a night driver, he cannot see anything beyond 4 meters clearly. So certainly, at 100 meters, he's going to have blurred vision, and nighttime again, and there are chances that he will get into, dash into something. The higher chances that his reflex will be slow, he will get an accident. And therefore, checking the refractive error between two surgeries. If the patient is left with minus 0.25 in the first eye, aim for plus 0.25 and vice versa. If we keep on doing all these things, look at the wound, whether the wound edema is there, the internal lip is closing or not. Many times the internal lip of the cataract incision remaining open, it induces 0.75 to 1.25 diopters of astigmatism. So you wait for that wound to close. One day it is going to close like a zip, and then suddenly the cylinder comes on. So if we plan accordingly, the unsatisfaction is like less. I'm sorry. Who said that nowadays having same experience?
Dr. Neha.
Yeah, thank you, Dr. Neha.
Okay, thank you, sir.
May I have a question, please?
Yes, sir.
You are on mute, sir.
You are muted.
Yeah. Can you hear me?
Yes.
Yeah. So I would like to ask Dr. Vavikar, what are his absolute indications for doing trifocal or multifocal lens? Absolute indications. We've been talking about contraindication.
So absolute indication is only one. Patient is highly motivated.
And he is willing to take all the pains.
Correct.
And willing to suffer even after paying so much of money.
No, if the patient is not a good candidate, like you are all aware that I operated on our CM Eknathji Shinde. So in his wife's eye, panoptics was implanted. Okay. And he wanted the same. Then I told him that, sir, don't do it. तुम्हाला ना लोकांच्या मनाला ते भाव कळणार नाही, कॉन्ट्रास्ट सेन्सिटिव्ह त्याला मीटिंग मध्ये तुमचा प्रॉब्लेम होईल. तर मला मग दे सो आय पुट व्हीव्हीटी. सो ही सेड की तुम्ही डॉक्टरांनी अशी लेन्स टाकली की मला पेशंटच्या माणसाच्या मनातलं पण सगळं कळेल. So many times, when you have a relative who has undergone multifocal, okay, the patient is highly motivated and somehow there are too many contraindications, even though small one. together it becomes a very bad picture. It becomes very difficult for the patient to convince don't go for multifocal. Then that is again the place where, you know, EDOF comes to our rescue.
बंद करी क्या? तुमने बंद करी क्या कुछ? लाइट गई ना?
Thank you, sir.
Thank you.
Any more questions?
Think
So,
over
Dr.
to
Rahul,
moderators now.
I think almost all questions are done. We can.
Yeah. Thank you, sir, for clearing all the doubts. I request Dr. Shadab to do the needful.
Thank you, sir. I hope I'm audible.
Yes, yes.
Yes, sir.
Yes. First and foremost, we would like to thank our national faculty, Dr. Vavikar sir and Dr. Ragini Parikh madam, for their excellent talks and opening our eyes towards multifocal and trifocal IOLs. Also, I would like to thank our own VOS faculty, Dr. Archana Thul and Dr. Mona Sune, for shedding light and enlightening us on pearls of management of subluxated cataracts and congenital cataract. I thank the Vardha Ophthalmological Society who has partnered with VOS for this webinar. Also, I would like to thank all our chairpersons, Dr. Smita Singh, Dr. Sachin Daigaone, co-chairpersons, Dr. Shashank Banayat, Dr. Sanjay Ostwal, moderators, Dr. Neha Deshpande, Dr. Dheeraj Jaiswal, and panelists, Dr. Ajay Khandewale, Dr. Durgesh Pashine, Dr. Abhay Agashe, Dr. Vijay Jeswani, Dr. Shreyas Dhamorikar, Dr. Ankit Harwani, and Dr. Advay Appalwar for helping to create and run this program smoothly. Last but not the least, I would like to thank the Entod Pharmaceutical Company for providing us with such a glitch-free and a smooth online platform so that we could conduct this whole program. And thank you all who have been listening and seeing us on Facebook, YouTube, and on other online platforms. Thank you and good night.
Thank
Good
you.
night.
Thank you, everybody.
Good night,
and
sir.
Thank you very much.
Thank you. Good night.
Thank you, everyone.
Good night,
Thank you,
everyone.
Vavikar sir.
Thank you.
Thank you, Vavikar sir.
Thank you. Thank you. Good night.
Good night, sir.